Hello everybody, warm welcome to today's ISQua webinar on role of health technology assessment in improving healthcare quality and safety. This webinar will discuss current health technology assessment practices and procedures and their role in improving the delivery of quality and safe healthcare in Australian setting. I would like to introduce you to today's presenter, Professor Guy Marden, who is the RP Chapson Professor of Surgery at the University of Adelaide. Professor Marden leads a high-profile clinical department and large and productive research group currently consisting of postdoctoral scientists, PhD and master's students, plus multiple research support staff. His clinical and research interests include the psychological impact of laparoscopic surgery, and more recently the development of techniques and measures to manage metastatic hepatic disease, and ultimately to develop novel prognostic clinical tests and preventive therapies for metastatic colorectal cancer. The evaluation of new technologies, and in particular surgical technologies, is another area of focus and interest. As surgical director, the Australian Safety and Efficacy Register of New Interventional Procedures, surgical ISER and IPS, has been responsible for assessing these technologies for the Australian and international community for the past 19 years and is recognized nationally and internationally as the premier surgical innovation assessment group. Just to remind you that today's presentation will take approximately 45 minutes, and we will leave the remainder of 15 minutes for any questions that you may have. We will be taking your questions during the presentation, so if you do have any questions, please type them into the question or chat box provided, and they will be posed to Professor Marden throughout the session. Now, enjoy the presentation, and over to you, Professor Marden.
Well, look, Thank you very much for that introduction. It's 8:30 at night in Adelaide. It's cold and it's the middle of our winter. So I hope that you'll understand I have a small cough and cold as we go through this. Medicine used to be simple, ineffective and relatively safe. Now it is complex, effective and potentially dangerous. And it's this change in the type of healthcare we're giving and the obligation on us to try and understand what we are doing to patients and what are the effects both short and long term that has really changed and brought to a head the need for us to assess our technologies. Now, safety is an ethical imperative in medicine, and we absolutely need to understand whether or not our interventions are in fact safe. But of course they're not always safe, and we should try with our interventions to, above all, do no harm wherever possible. Health technology is an intervention that may be used to promote health, to prevent, diagnose or treat disease, or for rehabilitation, or for long-term care. So we're not necessarily here talking about high-tech equipment or even sophisticated investigations. We may be talking about systems, diagnostic processes and management of patients so that we are able to intervene effectively with the level of knowledge and technology we have available. And so therefore it includes pharmaceuticals, devices, procedures and organisational systems used in healthcare. So obviously we understand pharmaceuticals, devices and procedures, but organisational systems might be something like home nursing, it might be something like day case surgery. There are a number of these interventions and systems that need very careful evaluation because often on the surface they seem to be very attractive, but when properly investigated they may not provide the benefits that were hoped for. So I think it's important to remember that not every individual may be as good as they seem. This is Baron Lord John Sewell from the House of Lords in London, and he was recently found to be somewhat less than perfection and a pillar of our community when his images of him snorting cocaine appeared widely through the media. And I'd suggest to you that we have in health similar devices, procedures, interventions and pharmaceuticals that appear to be equally as meritorious, but turn out not to be the case. The Bjork-Shiley heart valve is still one of the outstanding devices for a mechanical heart valve. Its flow characteristics are quite exceptional, and it's a concavo-convex valve, and it's still used today. However, as you can see on this image, there was a strut that was welded on to the main circuit of, or the main circular annulus of this valve. And what started to happen was that this weld eventually, with all of these endless movements of the valve, or the disc you can see there, what happened with this was that these welds broke, freeing the disc, rendering the valve useless, and leading to almost instantaneous death for the patients. It took a while for this to be understood, because these patients were dying suddenly, but they were cardiac patients and didn't always have autopsies. It took a while, therefore, to recognise what was happening, and that this was in fact a design fault. It was made even more difficult at the time because there were very poor registries in place, and it was very difficult to find out indeed who had even had these valves. It was known how many had been sold in countries, and and the company knew, of course, which hospitals had received them, but often the systems inside the hospitals were poorly developed to actually track who had received this sort of prosthetic device. It led to a lot of revelations in healthcare, in particular the need for some form of registry and the need to be able to follow and monitor clusters of behaviours that may not have been anticipated. The problem was actually solved by, instead of welding that strut onto the annulus that you can see there, they actually made the strut a moulded piece of the annulus, and that's why the valve has been very successful and is still used today without serious event. This is the Angel Chick anti-reflux device. This is a silicon donut that is put around the bottom end of the esophagus, just above the stomach. And you can see in the lower right-hand image there, it's tied together in a way that brings the donut around there. This stops the esophagus stretching out as the stomach distends, and is really very effective at controlling reflux. The difficulty with this device was that it also stopped your swallowing in a large number of cases, because as you can see, it's a fairly solid structure. There is no long-term give with it. When we do routine fundoplications, where we wrap the stomach around the esophagus, a more difficult procedure than placing one of these Angel Chick donuts, there is inevitably some give in the stomach, and so even if it's a bit tight in the early phase, it eventually stretches and swallowing becomes usually possible. This donut did not allow that, and it had a further major problem in that it is a foreign body, and this foreign body would would actually work its way through the esophagus into the stomach and was being passed per rectum. So this was a device that worked quite well for reflux control in about 85% of people. However, it had a very high rate of intractable dysphagia, and then had this even worse problem of perforating through and migrating. So again, there was really a very poor registry in place, and at the same time, there was very little understanding that these complications were occurring and were significant, and many people thought that they were having unique problems because there was no registry at the time. We actually reported our experience with this device and highlighted the fact that we felt it was a serious problem. I actually received hate mail from colleagues around the world who said that I was bringing to attention, or bringing into disrepute perhaps, an excellent operation and an excellent device, and that it's a terrible thing to be highlighting our bad results. In fact, 2 years after the paper, the device was off the market and has not returned. So it's another example of perceptions not being accurate, early good results not being borne out, and a reluctance to believe or accept poor outcomes. More recently, we've had the problems with the PIP breast implant. This is a silicone breast implant that is used for breast enhancement, but also used, of course, for patients post breast removal for cancer. This particular device had two significant problems. One, its rupture rate seems to be higher than most implants, although one has to acknowledge that if you leave a breast implant in long enough, particularly a silicone one such as this, there will be an appreciable rate of rupture. More importantly with this, perhaps, was that the manufacturer was using industrial grade silicon rather than medical grade silicon, and this of course is a criminal activity and not really one to do with monitoring health technology, in that it's arguable that industrial grade is worse. In fact, I understand the early breast implants were industrial grade as opposed to medical, but nonetheless it does show that we have two problems going on here. We always have to maintain quality control and ensure that fraud is not occurring, but that is really a separate issue from the issue of the durability and the appropriateness of the device, as I've highlighted already with the Bjork-Shiley heart valve and the Angel-Chick anti-reflux device. More recently, the ASR hip joint has been a major problem for Johnson & Johnson. This was a metal-on-metal hip joint. It has a lot of theoretical attractions. It looked like every other hip joint, or not every other hip joint, but many other hip joints. And this particular device caused a couple of major problems. It first of all seemed to liberate chromium and cobalt ions, which led to very high levels being recorded in the blood, sometimes thousands of times greater than would be accepted as normal. We're not exactly sure whether that matters a lot, but it does seem to be inherently an unsound situation where you do this, and what are the long-term effects are not really well known. The other particular problem with this was that it caused pseudotumors around the joint and a tremendous amount of pain, and the revision rate is probably going to be in excess of 50%, whereas normally you'd expect it to be 3 to perhaps 7%. This has been a huge problem. It's had the largest class action payouts of any medical device, certainly in Australia, and I understand also in the US. And again, part of the problem here was that there was registry data that highlighted there were issues with this joint, but there was resistance to accept it. The resistance came from the fact that the argument was made that they weren't being put in properly, the patients were perhaps inappropriate, and the joint was fine, but the selection and the surgeon were the problem. This turned out, of course, not to be correct, but regulatory agencies were slow to recognise this, despite what appeared to be very concerning data. And I think as a result of this, and I'll talk about it a little bit later, registries are powerful tools. They won't always be right, but they have to be taken very seriously. So what is health technology assessment? Well, it's research-based, practice-orientated assessment of relevant available knowledge on the direct and indirect consequences of technologies, as well as the indirect and unintended consequences. And the goal of health technology assessment is to provide input to decision-making in policy and practice. So health technology assessment is conducted by interdisciplinary groups. It uses explicit analytical frameworks, uses a variety of methods, including the synthesis of the evidence and indeed sometimes producing evidence. So in other words, you may be relying on evidence that's already out there available in the literature, or you may actually have to go out and seek specific evidence in order to provide some guidance to patients, doctors, hospitals, and government. And I'll give you some examples as we go along. But it must be understood that it has to be context orientated. It is not what works at the Mayo Clinic in the USA may be completely inappropriate in Adelaide in Australia. or in an environment where you've got fantastic access to imagery, imaging or close monitoring of patients, it may be an appropriate technology, whereas if you lack an intensive care or you lack interventional radiology, it may be completely inappropriate. So this is, of course, the problem. And it's all very well to look at reports from major centres with expert clinicians conducting interventions, but does this necessarily pertain when you roll this technology out across a broader and more general population? Obama recognised this, and very early in his first term of his presidency, he introduced comparative effectiveness research. And this was really one of the first times the United States had picked up this sort of concept. And he looked at how appropriate, or he encouraged and funded, appropriate assessment of technologies as they rolled out across the population, rather than just what the results were within a randomized controlled trial. This figure really tries to give you a sense of how we view the health technology life cycle. Initially, you have the flat part of the curve, which is showing you the early introduction and development of the technology. And then something begins to happen. It either becomes very much safer, or there's an intervention that enables you to do this more easily, or there's a monitoring that makes it better, or a product characteristic changes, and then suddenly this technology starts to take off. And you have early adopters, and then if it's going well, or appears to be going well, it rises rapidly in use. And then, as you can see, it may follow the dotted line and become obsolete quite quickly because problems are found longer term, or it may become a durable and long-lasting intervention that may well stand the test of time. The issue here, of course, is that we are looking to do a health technology assessment at that period before the curve takes off. But as I hope you can also understand, it's really quite difficult to know when that curve is going to suddenly take off, because it may well be waiting for an enabler that lets us introduce this technology safely and widely. And so if you take, for an example, if we go back to the Bjork-Shiley heart valve, it was incredibly popular, it was widely used, and then there was a serious problem with it, which fortunately was able to be addressed. Whereas if you talk about the angel chick donut that went around the esophagus, it too took a while to take off. It then took off, but the problem was that it had some serious problems that took a while to be recognised, and then it sort of dropped completely out of practice. So when you're thinking about a health technology, you do have to understand that these are the type of factors that are in play. And of course, we have lots of technologies that have been made available. This is a drug-eluting stent. Now, before this, there were bare metal stents. Then they introduced drug-eluting stents, which were thought to be a major step forward, because what it would mean is that we were able to place stents and maintain the patency of them by having a slow elution of drugs to maintain the epithelial lining. But it created a whole lot of other issues. Many of these patients needed to stay on very long-term anticoagulation. We now have a large number of patients who are on long-term anticoagulation getting serious surgical problems as a result of their cardiac stents, and often making operative intervention very, very difficult and sometimes fatal. So there are issues with these sorts of technologies, and obviously one needs to balance them. But I have to say, I think in this example, there was enormous enthusiasm without thinking through the implications of long-term anticoagulation in a broader and general population. More recently, there's been NOTES, which is natural orifice surgery. This is a technology where you can pass a scope through the vagina of a woman, perforate the vagina, go out into the abdominal cavity and do a cholecystectomy on these women without the need to actually make any puncture wounds in their abdomen. And this again is an interesting technology which has, I think, been brought in very slowly. It hasn't really taken off, partly because it's technically very demanding. The instrumentation is still not ideal, and there really already is an extraordinarily good operation that can be done, a laparoscopic cholecystectomy, making this not a particular advantage unless you are obsessed with avoiding any form of abdominal scarring, which for most patients is probably not the most important issue. It was interesting, in this particular technology, they did a survey in the United States theoretically asking if there was a 2% risk of painful intercourse lifelong as a result of this operation, would you accept it? And the women largely did. We did the same survey in Australia where women said no, they would not accept a 2% risk of painful intercourse as a result of the procedure. And so again, it just emphasises the context in where you're introducing a technology. It may be American women would prefer not to have scars and have an incidence of painful intercourse, and whereas Australian women may view this in reverse. But it is something that needs to be borne in mind, and this may well be a technology that does take off as time goes on, but it is a way off yet, I think. To get around some of these problems, there was this intervention, which is called SILS, which is single orifice surgery, where you have these very complicated instruments that can perform cholecystectomies. This operation also is technically more difficult than a routine laparoscopic cholecystectomy, and it really hasn't taken off. Some use it as a marketing operation, but really patient benefit, cost and time has not really indicated it's particularly successful. Now, if I just have a drink for one moment. The issues for new technologies that really need to be considered are safety, effectiveness, cost effectiveness, durability, comparative effectiveness, that's that concept of rolling it out across a broad community rather than just inside a randomized controlled trial, training, and from these we then have to look at the various steps as we assess a new technology. Can it work? What is its efficacy? What is its effectiveness? What is the appropriateness and the context in where you're going to introduce this? And then how do you implement it? And I just would like to emphasize that with many of these health technologies, the training is very important. I'm not going to talk tonight about pharmaceuticals. I'm a surgeon. I don't particularly understand many issues in pharmaceuticals, but the training that's needed to show someone how to give a pill is very different from the training that's needed to teach a surgical intervention, set up a system of delivery, and monitor the long-term outcomes of procedures and devices. So when you're considering these things, you really do need to, if you're looking at devices and procedures and systems, you do need to think about whether this can be implemented within the environment where you work. This goes back, of course, to the introduction of many of these technologies, and as was mentioned in the introduction, I've been the surgical director of ASNIP, which is an organisation supported by the Royal Australasian College of Surgeons. And this organisation is charged with looking at new technologies as they relate to surgery. We got interested in this when laparoscopic cholecystectomy arrived into the World Surgical Armamentarium. This is a newspaper clipping from the United States advertising no long recovery, no long scar for laparoscopic cholecystectomy. And this led to a rush to use this operation. Patients wanted it, and I think rightly so. Surgeons wanted to offer it, and they were terrified they were going to lose business if they couldn't do the operation. And there were some disastrous complications because people were poorly trained, didn't understand the new risks that came with this operation. And it was as a result of this that the College of Surgeons set up the ASNIP program to look at new technologies at whatever point in the cycle they existed. And so the evolution of a new technology is shown here. You have your laboratory studies, you have your case series and case reports, you then get into incidental comparisons, you then have planned prospective analysis, which may be a non-randomized study, or it may be a randomized controlled trial, and then you have audit, where you actually collect the data as the procedure is rolled out into the community. Now, this is in fact not one of my operating theatres. This is in fact a representation of how many people perhaps see surgeons and the way they develop things. It's not quite as bad as this, but you must understand that many new things in surgery often happen spontaneously. They're done to solve a particular problem, and sometimes they are unbelievably successful, and sometimes they can be complete disasters. In order to sort of help surgeons understand how they should introduce technologies, a group of surgeons, methodologists, trialists and statisticians got together over a number of years in Balliol College in Oxford to meet and to discuss what turned out to be the ideal collaboration. And this set out to provide a framework which surgeons could use to look at, appreciate and understand new technologies as they arrive. So the first stage was stage one, of ideal. The question was, can the procedural device achieve a specific physical or physiological goal? And it's a proof of concept. You might only have one patient where it worked, and there are many examples of this. And then you have a first-in-man study. And for example, you might be doing stem cell-based tracheal transplant for tracheal stenosis. So you have this idea and you experiment on it and then you introduce it. Then you have the development. This is the D of ideal. What is the optimal technique or design, and for which patients does it work best? And you're looking here to see that it's safe or reasonably safe and whether it works. And you might have a dozen patients. You may not have large numbers. And what you're trying to do is set up a prospective development study where you're altering the procedure based on your experience in doing it, so that you may find that it needs modification and correction. Although the fundamentals might be good, you use this experience, this development phase, to adjust it. There are many examples of this that you could bring up. This is the portal vein ligation combined with in situ splitting, is a technique to try and enable you to take bigger liver resections from patients that require it for metastatic liver disease. And this is an operation that has undergone a lot of adjustment and correction over time from when it was first reported in this paper. Then you move into this exploration. What are the outcomes of more widespread use, and can you reach an equipoise before you head off into a trial? And you might need several hundred patients to do this, and to see how feasible a trial would be. Because what you're going to need is equipoise. You're going to need surgeons to, I apologise for my cold, you need surgeons to agree that this intervention could be of benefit and are therefore prepared to enrol patients in it. Once they have developed a view that this is fantastic or it's terrible, then of course that equipoise is lost and it becomes very difficult to enrol patients one way or the other. And the example I gave earlier of SILS is perhaps a good one. There are now some reasonable trials coming out on this, and I would suggest to you that these trials have not shown SILS to be superior in anything other than a few less 5mm scars on the abdominal cavity. And then you need these assessments. How well does this procedure work compared to current standards of care? You need comparative effectiveness. You need hundreds of patients. You need randomized controlled trials if you can get them. And indeed, we originally started this ideal collaboration believing that it was not realistic to get high-quality randomized controlled trials in surgery. as we developed our thoughts on this, we came to the conclusion that was absolutely not correct. And generally, we now believe very strongly that randomised controlled trials should underpin any assessment of a surgical technology, and we should not find excuses not to do it. And an example of this might be robotic pancreas resections. As you know, there are these surgical robots. There are some who say robotic pancreas resection is a perfectly reasonable intervention, and we should be doing randomised controlled trials to demonstrate whether that is really the case. And this is a picture of the robot, which can be used for all sorts of procedures. As you know, it started out with mainly being used in prostatic surgery, and it's interesting, only this last week there's been a publication released from a group in Queensland who looked at the robot doing prostatic resections versus the open operation, and they found it to be no different in terms of the outcome, except for a substantially increased cost. But then you need long-term studies. What are the long-term effects and outcomes of the procedure? Quality assurance, larger patient base, and you need observational studies to look at this. So such things that we have out of these are the endoluminal aortic stents that you can put in and try and assess whether or not they work in the long term. However, with all of this, even if you have good RCTs, we do have the issue of looking at what is typical in surgery. And we don't have good RCTs to draw on. And I don't want to spend too much time on this, but the TEM is transanal endoscopic microsurgery, and when this was being rolled out in Australia, or trying to be rolled out in Australia, we could only get one RCT to draw on. There was the intraoperative radiation treatment for breast cancers, IORT, and again, there was only one RCT to draw on. So RCTs are rare in surgery, unfortunately. There was LLDN, living-related laparoscopic donor nephrectomies for transplants, and again, we introduced this into Australia, but we only had one RCT, and we set about collecting prospective data on its success. And there is also an example, however, of stapled hemorrhoidectomy where we had a lot of RCTs, we had excellent evidence that in the short term it seemed to work, but it was in fact not all that durable long term. And so although we got an early answer that said this was reasonable, the long term answer has largely suggested it's not an ideal intervention, although some people still pursue it. We're always looking on the horizon, and as you can imagine, it took a long time to get this picture, but we're always looking at new interventions and new possibilities, and of course we do need to provide assessment on these. And horizon scanning has grown up to provide early warning for new techniques on the horizon so that doctors, hospitals, governments can have some warning that something might be about to arise that could revolutionise the healthcare system. And there are many of these. This is a margin probe for looking at cancer, whether you've removed all the cancer from the specimen. Does it work? We don't know. This is the MGuard stent, which is a biodegradable stent. Is it really viable to use for coronary artery disease? Maybe. Artificial hearts, again, expensive. Are they really a useful, ideal resource? Hard to know. Anal fistula plugs. This is a plug. You can see it in the right-hand picture there being put into an anal fistula. Difficult problem, hard to manage, difficult to treat. But again, do these actually offer an improvement on conventional treatment? Circumferential endoscopic radiofrequency ablation of Barrett's esophagus. This technology does work. It does remove the Barrett's, but does it actually lower the risk of cancer forming in an established Barrett's that's been treated like this? Again, not known. If we want to try really bizarre interventions, we can do robotic-assisted endoscopic thyroidectomies. This is an operation that can technically be done. You pass the robot arms through the axilla of patients and remove the thyroid. It's expensive. It's not really been demonstrated to be a great advantage. And when you can do the same operation through a very small incision in the neck, you have to wonder whether this is appropriate. This is an operation for plicating a stomach, where you plicate the stomach and reduce its size so that patients can lose their weight. And then when they start stretching their stomach up, you can go back and do it again. Does it work? Not known. This is a procedure for looking at trying to prevent reflux disease. Again, it was thought to be a wonderful step forward, and when it was introduced, it turned out to be something of a disaster. In fact, we reviewed a number of the treatments for reflux disease. There was the Stretter procedure, there was the Barrett endo clinch, and there was the Enterix. And when we reviewed them, we said a lot more work needed to be done. They were still being used at the time, and subsequently they have virtually all disappeared. Endobronchial valves are another example. Very expensive, about $9,000 to use one of these. People put multiple ones in, as you can see in these images, and whether or not they provide the benefit for the wide range of patients that receive them, I think is still very contentious. So we do have systematic reviews, and they are very valuable. This is where you pull together the existing evidence, which, unlike Cochrane, which focuses only on RCTs, we've been looking at all of the evidence we can lay our hands on, including, of course, RCTs if they exist. You need a defined question, you need a defined comparator, and you need a clear protocol, database, search terms, language restrictions, etc. For example, you can do this on devices and procedures, as I mentioned, but we've also done it looking at training devices. This is looking at high fidelity versus low fidelity simulation trainers for surgeons. And this is the typical low fidelity where you just have a box and a few squares that you move between pegs. Or you can have one of these incredibly sophisticated computer systems, which of course look a bit more realistic. And what we found when we looked at this was, despite the fact that the box costs about $3,000 or $4,000, and this costs about $100,000 to $150,000, we found that the box actually did the job better than these much more sophisticated high-fidelity systems. So you need RCTs because sometimes non-RCTs of the same question may show the same finding as the RCTs, but more commonly, non-RCTs show more favourable effects for the experimental intervention than the RCT. And our big trouble is we cannot predict which non-RCTs will show inflated results. So in a perfect world, we want RCTs. Adverse events are underreported in all study types and are hard to quantify the extent of this. And so underreporting and not publishing is a huge problem, and we really have to encourage people to publish results that may not be all that flattering for their intervention. We also need to try and report in a standard way, and OMERAC, and Clavien-Dindo classification were all designed to standardise how we report outcomes. And this is, of course, one of the problems. There is no point in having the Vancouver system, the Adelaide system, the London system. You need to adopt internationally approved systems rather than create boutique ones. And long-term follow-up is a huge problem. There is a big tension between evaluating new procedures and assessing durability. This is the hernia stapler, not the hernia stapler, I'm sorry, the hemorrhoid stapler I was talking about earlier. And this cost $700 odd. It was very effective, well, fairly effective short-term, but did not have long-term durability. Similarly, if we're going to look at a knee replacement, we need to be able to believe and know that this replacement works longer than just the first 6 or 12 months after insertion. Similarly, with prostatic operations, we've had good examples of very effective technologies that have worked for the first 6 months and then over time had quite high failure rates, whereas other procedures have been much more durable. I referred earlier to the arthroscopy or the issue with the arthroplasty and the ASR hip joint, and the Australian Joint Registry, which collects every joint that goes into an Australian patient and every joint that comes out of an Australian patient, showed the first early sign that this joint was not working well. And as a result of that, we flagged it here in Australia several years before the rest of the world. It was a shame the rest of the world didn't believe our registry, because a lot of patients could have avoided the problems that they suffered as a result of this joint that just did not work as advertised. So, as I've mentioned earlier, and I just want to reiterate, in looking at health technology assessments, you do have to look at context specific. And this is, of course, absolutely essential. So please be careful when you look at a published paper that seems to offer a great improvement. Just try and understand what was the context it was introduced in, because if the context is different, you can get very different results. And we had an unbelievable example almost in Australia where we introduced a contraceptive device in the non-dominant arm of women, and we had 50 pregnancies within the first year. And it was because GPs are not trained as well in Australia as they are in Europe. Well, in fact, that's not true. They're not trained as well in Australia, and they're the ones who do these procedures. In Europe, this is largely done by gynecologists who are very good at putting these devices in. And so we had to modify our training. The device was identical. It was the training that was not adequate. So most HTA provides more questions than answers. What is the evidence that the core heart valve, actually works? And one of the ways of trying to get this evidence is to get coverage with evidence. And the advantages are that you get the new procedure earlier, you get tightly controlled data, and you get a clear decision point. But the disadvantages are that you bring this technology in poorly evaluated, it's difficult to withdraw once it's arrived, and you get caught up with conflicts of interest, where manufacturers want one outcome, surgeons want another, and the poor patient is caught in the middle. And conflict of interest is one of the big problems of new technologies, particularly in devices and procedures, because often individuals are looking to try and establish a career or indeed have an income at the expense of the patient being the source of the evaluation. To try and get around all of this, the College of Surgeons developed this booklet, and it's available through the College of Surgeons website. It's freely available, and it outlines how a hospital might checklist the things that need to occur before a new technology is introduced. It's not hard to do. If you are serious about a new technology and understand it, you would have very little trouble filling out the questions, or answering the questions. And if you know nothing about it and really have been more impressed by a spectacular presentation rather than a lot of science, you'd have great difficulty. So as time goes on, we will be getting rid of new technologies. The angel check will be crushed and removed. The trouble is, just as quickly as we evaluate interventions as being unsatisfactory, they reappear in new forms and seductive guises. And we just need to be careful that before we take on the new Ferrari, we really know how well it's going to perform. So that brings me to the end of this talk. Really what I want to try and emphasize is we do have tools to look at technologies and devices. There are approaches. They're not perfect, but they work fairly well and they're fairly robust. And so I think we should be using these. And I think when we use them, and when we use them well, they do provide a much safer healthcare system. They don't stifle innovation, but they do encourage us to evaluate it thoroughly before we introduce it. So I hope that's been of some use and at least opens the concept of health technology assessment to you. And it appears I may have some questions, and I think they're going to be put to me.
Thank you so much, Professor Murray, for this fantastic presentation. We do have indeed a couple of questions, and I suppose we should start with looking after them first. So the first one is from Babatunde Fakula, and she's thanking you for this brilliant presentation and asking about, do you think computer-assisted simulation has a strong role in introducing new technology into healthcare?
Look, I think that one of the difficulties we have at the moment with computer-assisted simulation is that it certainly can help with the training. There are a number of computer simulations of varying sorts. One of the ones I would particularly refer to is there is a colonoscopic simulator which can train surgeons up to about the level of the first 50 colonoscopic examinations, and it really does teach them the skills and the techniques and the sequencing. But after that, unfortunately, you really do have to learn with patients, obviously under supervision. So I think that's the best example. There is, however, great interest in actually introducing computer simulation where you use a lot of the imaging that's available and can construct a 3D simulation that lets you actually practice the operation you want to perform in a simulated form, so you can perhaps foresee some of the problems. Now, surgeons, in this particular example, I guess we do the 3D simulation ourselves by looking at imagery and examining the patient and our understanding of anatomy and its variations. But if you can actually have the real patient's anatomy presented to you in a form that you can easily take on board, I think that offers enormous potential. So I do think these sorts of things are going to become more available, and I don't think you need it for routine stuff, of course, but for complex new interventions, I think there is a lot to be made available, because you can then also attempt things that you would not necessarily want to attempt in real life, but you can do it in a simulator and maybe find it actually makes a substantial difference to your operation or your approach or your use of the device. So yes, look, I think it's coming, but it hasn't quite arrived.
Thank you so much, Professor Martin. The next question is from Inas Nafi, and the question stands as follows. What are the other tools, in addition to FEMA, that can be introduced early to detect early the electronic hazards?
Sorry, I think I need, I'm not sure I know what FEMA is.
We can just postpone this question for the moment because I'm not sure myself. So we'll ask Inas to to put that in, and we will address that question a bit later. And at the moment, we will address maybe our next question. Inas, please do come back to us and let us know what FEMA stands for. Proactive assessment came in here as an answer from Inas. If you can just give us an abbreviation, failure mode effect analysis. Right.
Well, I mean, look, I think electronic hazards, you've taken me a little out of my comfort zone with this question, Ines. I am not entirely over this. I have to say, I have had very limited experience, both practically and also in assessment of electronic failures. Because of course we're not, and I guess this probably pertains to things such as stimulators and pacemakers and defibrillators and these sorts of interventions. But look, I think generally speaking, the more extensive testing that can be done, the more valuable the information. And we certainly saw that with the ASR Joint, which didn't have as much testing as it should have had, and had that been done, as later tests showed, we would have probably had a very better idea of the problems of the wear that occurs. So look, as a general rule, the more testing the better, but I'm afraid when you take me into electronics, I'm a little out of my depth.
Thank you so much, Professor Martin. The next question is from Ahmad Bilal, and he's thanking you for this excellent presentation. And in terms of your own experience, what suggestions or what guidelines can you give, I suppose, in terms of introduction, the concept of HIT in the hospital?
Well, look, HTA has been introduced, and HTAs in hospitals are actually quite what's the word? They're gaining in popularity. So in other words, what that means is a hospital has a committee or a structure that looks at a health technology assessment, a new intervention, and then it goes and tries to source the information around that, which may in fact be systematic reviews, it may be health technology assessments that have been done in other places, and then it brings it back to the local hospital, and that's that context issue I was talking about, and decides whether or not it's got a place in that particular facility. The problem with this, and I mean, it's a great initiative, but the problem with it is you do need quite a bit of resource. The hospital has to support it. But if you have it and you use it well, you can stop a lot of very inappropriate procedures being introduced. And the other advantage it has is for administrators, I think. Administrators often don't have the skills to talk to surgeons or doctors about why a technology may not be appropriate. And as a result of that, often technologies can be pushed through by forceful personalities. If you have an HTA structure inside your hospital, then the evidence can be used to control this exuberance rather than the forceful personality. So I think we're going to see a lot more HTAs within hospital systems or within local health systems, and they do work.
Thank you, Professor Marden. And the next question is from Devi Indriani. And again, you've been thanked for this very informative presentation. And in terms of the question, you have mentioned that introducing the new technology will involve so many conflict of interest. And I suppose the advice that Devi is looking for is how do you deal with it?
Well, look, it's not easy. And I think that you do need to ask the individuals who are putting up a procedure, what are their conflicts or what are their potential conflicts. And I mean, sometimes this can be very obvious, of course. It can be that they are wanting to deal with a problem that's great for them, but also it can be because they, they have a financial interest in the company, they have a financial interest in the product, they are trying to establish a practice which has not been going very well until now. And I think you do have to sit down with them and, and explore those issues with them. Because if you don't, then individuals will bring out things that clearly are not working well and will be pushing it for the wrong reason. And there are all sorts of very subtle conflicts, but if they're not discussed and they're not aired and they're not declared, then there is just no way you can deal with them. But look, it's not easy, and I'm not saying we've got it right.
Thank you, Professor Marden. The next question is there any place for health information, for health assessment technology during the implementation and testing phases of health technology products? And if there is, can this be regulated?
Yeah, well, look, I was sort of touching on this with this coverage with evidence, which I brought in a bit late in the talk. But the coverage with evidence approach is where you have a technology that looks promising. It's perhaps meeting an unmet need. So, if you have another hip joint, you would argue, well, we've got plenty, we don't need a new one. But if you've got the core heart valve, where you've got a percutaneous valve that can be placed into the aortic root via the groin, it's a day procedure, and you can do this in very old patients who would never tolerate an operation, then that is something that is providing an unmet need. And you do need to bring that in it's valuable to bring that in fairly early. But if you're going to do that, you absolutely need to collect the results. You cannot allow this to be put in and not follow up these patients, because if they're all dying at 6 months, then you haven't done them any favours at all. But if, on the other hand, at 2 or 3 years they're still doing well, it's a very, very major advance. So there are examples of this. We did this with endoluminal aortic aneurysm repairs, where we collected the evidence when we really weren't sure whether this was going to be a durable intervention. And we were able to report back to our government that in fact it was durable, and that just supported the long-term introduction of this technology. So I think it's a valuable approach, but I think it's only when you have a technology that offers such a significant advance that it's worth doing it.
Thank you so much, Dr. Marden, Professor Marden. We have one last question. What is the best way to report issues associated with HAT in countries where there is no HAT? You have mentioned publishing is one way, but would you be able to expand on other ways to report those issues?
Well, look, it is difficult. I mean, I think health technology assessment, the most important thing we can be doing is trying to report results, or if there are registries, feeding into those registries so that individuals can have access to it. Health technology assessment, in many ways, of course, can be accessed. It's available on the web. There are some excellent health technology assessment reviews. There are agencies around the world that are doing this. I mean, there are many, many agencies that do it, and they are feeding into the WHO, and one can have access to these even if you don't have sophisticated HTA assessments within your area or country or jurisdiction. The only flaw with this, of course, is this issue of the context, that a procedure that works well in a first world country may not work well in a third world country because the infrastructure to support it may not be there. But look, I think you can get a pretty good idea on whether or not something is going to work from both the published and the widely disseminated information through the WHO. And while it's not perfect, none of this is perfect, it is extraordinarily useful.
Thank you so much, Professor Martin, and thank you for this insightful and very interesting session in terms of the health technology assessment practices and procedures and their role in improving the delivery of quality and safety in healthcare. So thank you so much for sharing your knowledge and expertise, and on behalf of ISQua, I would like to thank you for doing such great work in your field, because who knows where we would be if it wasn't for the work that you're doing. So thank you so much for presenting to us and for what you do on a day-to-day basis.
Well, thanks very much for the opportunity. I've really quite enjoyed trying to do this. It's been a technological challenge, but it's been good fun, so thank you.
Thank you. Thank you to our participants for attending and joining us today, and goodbye for today.